We'll be talking about that later on. But I thought I'd just, for starters, give a bit of reflection of where the programme is, having been created around 2020 on the back of an envelope by me, to a quite complex and really interesting range of work that's going on. Again, just that's the complete care community. It's communities, the hashtag that users handle. It says complete care community, doesn't it? It's IES. Sorry, we got that wrong. I'm quite excited about this talk as well because I've not heard it myself. So whatever comes up. So yes, I'll correct everything that may be right or wrong. Just to set the scene, I know it's going to come as a shock to you with such youthful looks to say I've been in the NHS for 40 years. I know it's hard to believe. But during those 40 years, and I've had 2 stints at the Department of Health as an advisor, there's always been a policy driver which was, whatever the policy drivers have been, access, waiting, plurality of provision, and health and equalities, which we mustn't forget. And it's been the one that's been almost, not quite the Cinderella subject, but it's which hasn't necessarily been delivered. So again, it's good to have the focus on some of the, of course, we'll be hearing from colleagues from very senior positions or chairs of ICBs about the remit now is very much in the commissioning programme. But we know this, but we're doing through the programme probably a refreshed strategy in as much that from individual projects, is there information that we can glean from these that are generalisable? Can they be transferred so that it becomes a sustainable approach in the design of approaches that can address health inequalities? And we set 2 exam questions at the start. It's a bit emotive, but if we accept the research, whether it be from Sir Michael Marmot, who sent his apologies, he was asked to come but wasn't unable, whether it's been the other research, which sometimes almost just admires the extent of the problem and describes it over and over again. So despite some fantastic projects by enthusiastic people over many years, we still hear that the health inequalities gap is getting wider. I'm tired of hearing the social gradient we know is getting steeper. Even life expectancy, which has stalled for the first time in 150 years. More children in poverty. So we know the extent of the problem, so why haven't we solved it? And the Complete Care Community Programme is a learning network to try and address some of those issues that might start to build an evidence base and knowledge base that can be built into a more sustainable approach. And particularly whilst we talk about, again, I'm exhausted about the wider determinants, the social determinants of health. And of course, during my time as a GP, I think by the end of my time of saying what is good health, it was almost, have you got a home, a job and a friend? Because we know how to treat type 2 diabetes, but if you've got a home, a job and a friend, you've got type 2 diabetes, you will live a long and healthy life. We know how to treat it. If you've got type 2 diabetes and you haven't got a home, a job and a friend, you're in big trouble. Same disease, much earlier complications or earlier death. So what in the new construct, the macro system of the NHS being the ICB, the micro system being the primary care network, and then this sort of jelly-like middle bit, the place, which you can ask 100 people what they mean by place and you get 101 answers, maybe being a bit unfair, but I guess it is related to a larger footprint akin to a council ward or how we link in with wider council and other community services. So what can the NHS do? And my colleague Pete Smith often says, well, the research that says it's only about 20% is almost an excuse. It's very old research, and we probably can do a lot more in the NHS if we focus our efforts slightly differently, build an evidence base, and probably have a bit different allocative value in how we place resources. Where we're at, colleagues in the room will know this already, 3 phases, 65 sites, variable activity, and the PMO, which is working with them, our PMO interacts somewhere between on a monthly basis. Some are now going to quarterly because they don't need so much input from the team. And the spread, we wanted to make sure that over the 3 phases, it's an English programme. I'm sure it translates across the UK, but we wanted to make sure we had good geographic spread, so we didn't have the oh, but it would never work. I remember in my early days, Pierce will remember this, as a young GP who was enthusiastic, doing some good stuff, but probably portrayed this success in the wrong way by going, oh, look at us, what we're doing. And I was in Wallasey, but colleagues in Birkenhead would say, it'll never work in Birkenhead, James. We've a very, very different population 2 miles down the road. So that translation of learning, we wanted to make sure that we weren't going to build in something it's all very well in Nottingham or Norwich or Newcastle, but it'll never work elsewhere, as opposed to saying, no, we've found some principles independent of geography because it's working in Brighton and Barnsley and Bolton. And similarly, the style of project was, it doesn't really matter. Of course, it matters to the local people, but what within the project is transferable, whether you're looking after whatever the marginalised community is, whether it's inclusion health, whether it's some aspects that link in with the core 20+5, what can we transfer independent of the project? So that's where we're at. This is the pretentious bit that's called Case 7, the Kingsland 7. But these are the principles where we've found that it's really hard work, but some of the issues that if we're starting to develop new projects, the first thing is, and I've seen transformation in so many titles of people working in the health service now, and often it translates to quality improvement. You know, can we do better with what we've got, as opposed to changing it, maybe having a blank sheet to design something new. And transformation, when we've been saying to sites who sometimes have to reset, some of our first wave said, we started down this path, but it got into deep water, it was wrong. So we reset, we recalibrated, and we've started off on a new process. So it's experimental to a point, structured, sequential, but transformation sometimes has to accept that we are doing experiments that might go wrong. And it's a very difficult thing for the NHS to accept when you've been resourced to say, actually, we've made a big mistake here, but at least we know why, and we can reset and do something different. And there's no ideal set of circumstances. When do we start? Well, I was really surprised when we were talking to some sites and funders were saying, around October when we were looking at some different, I didn't realise that winter was coming, because that's never happened before. So when is the right time to start? There's never an ideal set of circumstances, but it's a case of, can we galvanise, engender and enthuse, as this room has shown, despite the pressures on the service, the pressures in day-to-day work. There's some fantastic things going on, in addition to everything else that you've got to do. The leadership that we're seeing in this is not positional, it's very purposeful. And what we're seeing is liberating the leader inside everybody who works in health and care. They've got certain things that in their style of practice, it's just recognising that and liberating it. And similarly, that I think that, and I mean the biggest financial risk I see in the NHS at the moment is staff morale. And we've got to a point where, sadly, colleagues are on strike because of issues that I don't think are just related to money, but how do you strike to say, I want to be treated nicely, be kinder to me, the environment I'm working in is too stressful. But it's a case of, I can do nothing else, I might as well have more money for it then. And we've got to a stage where what we're trying to distill from the programme is that, how do we transfer that enthusiasm, instill it in people who are under great stress. And then the workforce as well. Primary care networks sometimes default a little bit to the aggregate of general practice. What we're finding is the leadership in the programmes are from all sorts of health and care professionals who are rightly leading a project on behalf of sometimes the primary care network, but there's a very different style and a different team-based approach, rather than, with respect, ARS funding, very welcome to a point, but to prescribe it and tell you which species you can have, as opposed to looking at functions and skills and competencies that are required in a workforce team which may not have the usual people. And we're seeing some really interesting teams being developed through the projects. So these are, again, we'll share these slides widely, but I was challenged with, if you're going to say anything at the start, James, at least try and distill something from the project that can be translated. So these were the things that, as you're starting, the hard work of change. And similarly, this is Muir Gray's work, but what we're finding is that if we're going to take I'm tired of different definitions of population healthcare and its management, which are different, but what all the projects are doing is defining a group of people who are characterised by certain qualities, and those qualities may be lack of shelter, lack of, you fill in the blank, but there's a group of people who are clearly defined, and each and every one of those people in that group are known. And even to a point where you know their shoe size and what they had for breakfast, as opposed to developing a service on behalf of a particular problem, people without shelter, and hoping, almost like the field of dreams, build a service and they will come. And with this sort of service, we find that they don't unless you really know and have a deep understanding of the debility experienced by a group of people, so that we can have that focus on groups of people in a population and build that into a population approach. Again, we're on the right-hand side of this slide of what we're trying to achieve. The last one is interesting, with clinicians responsible for stewardship of resources. I'm a bit loath to say give them a budget, but what we found, one of the issues that almost every site has said, we gave a contribution to the costs of being involved in the programme. It was only 40,000, I know not everybody got that, but there was a contribution of £40,000 to a site, which has lasted far longer than the annual process that is sometimes required. And we didn't ask them what they were spending on. We said, this is just a contribution to allow you to be involved. How you spend it, we don't want to know, but we do want to know that it allows you to engage and develop a project. And most sites said that was so liberating, because we never get that. PCNs tell us that most of the time we spend is we're chasing around for small aliquots of money and filling in forms to make sure we get it, and we never get around to doing the work. So that stewardship of resources, by trusting new groups of people to say, there's only a limited amount, we've only got this to spend, but can you help us spend it from the Commissioner's point of view in a different way? One word as well we're finding about allocative value. If we're looking at value-based healthcare, the focus for lots of projects is the allocative value, the value, the personal value, the people who are experiencing the care. We'll be hearing a bit about that later on. What is the experience of those people in those patient groups from a new service? We are starting to look at the utilisation of resources as a result of the new projects. Is it changing pathways? Are we, yes, debulking A&E, which is going to be a big metric for the NHS? But do we have an approach that can describe how the allocative value, how resources are allocated to projects like the CCCP and others that recognise that as a result of reallocation, sometimes the institutions have got to change? And I think if we can't have that conversation, let's not start, because I'm tired from, I'm going to say the F word now, fund holding when I first started, which started to say, well, we can move so much work from one sector to another. It's not a sector war, but if we move low-tech, low-complex work out of medical outpatients into a community setting, it was widely accepted by our hospital colleagues and consultants going, brilliant, there's so much to be done. But when the discussion was, and therefore the resource moves, and maybe we then close outpatients, it's dead body time. So unless we recognise that, we've got to have those difficult conversations as we move into commissioning for health and equalities. Just a final slide of some of the big ticket issues, because whilst we look at projects and the evaluation and the better outcomes for groups of people, we're finding there's certain things from all of the sites that are starting to question some of the fundamentals of the NHS. So registration, groups of people who are disconnected or not receiving the service that they need or should have, often aren't registered through the usual process. Do not like going to the place of care which is prescribed. And some of the sites have started to look at different ways of connecting people, registering them, but reaching out in different ways and having the first contact in a very different venue. which might question the estate's arrangements. Colleagues in this room have got, there's no point having a static estate for certain people. They've got a mobile estate, but learning what we mean by a mobile estate and the issues that need to be addressed for the health bus, for example. How we translate for people who don't have English as their first language. I've checked the literature. That new term, you heard it first here, or some have heard it, language empathy. We talk, there's the Americanism of language concordance, which is translating one language into another. But what lots of sites have found, whilst there's translators that might change one language into English, the empathy, the understanding, the expectation, the fears of the person to translate into medical language is very different than an interpreter who may be skilled but was working with the justice system in the morning and then the health system in the afternoon, translates language that sometimes does not portray the concerns of the individual. And there's one site, I'm not sure whether colleagues from here, from that site, have used ARS funding. They were told they couldn't do it, but they did it anyway and employed a full-time, not saying this is the right thing for ARS funding, but they needed, because of a large community of Slovak people in an inner city, were not using the services that had been designed for them. And they had a translator that knew a little bit about the community, but by employing that translator into a healthy environment, the utilisation of the resources that were there anyway has increased dramatically. And they now, who would have thought with ARS funding you can use it for a Slovak translator? You can't prescribe that in contract. What you've got to do is say that there's a resource here to improve the utilisation or improve the team that can utilise services better. It's amazing what people will come up with. So we've found a lot of things that we need to explore further around registration, around estates, around place of care, which we didn't expect. I was saying earlier, some of the discussions that I have and colleagues, I sit there open-mouthed going, wow, because some of the things that are being revealed that can translate into policy. We've stayed close with DHSC, and certainly I've got a statement from a colleague who's the head of primary and community services at DHSC, who was saying this is the sort of thing we need to build into policy in the future. We need to learn from this programme, so we're going to build on that. But at that point, I've probably said more than I should have said. I can see some of my colleagues going, just like being at home. Shut up, Dad. So I think the important part now is to, with that background of the current programme, is to ask colleagues now to join me on stage where we're going to extend the discussion. We do want to make this discussion, albeit colleagues will be setting the background from either senior positions, from chairs of ICBs, from national viewpoints from public health, from regional officers commissioning, and from working with, I've heard lots of times that is it the independent sector, the third sector, the charity sector, but the sector where we know there's huge resource, huge expertise, and we talk about let's just incorporate it, but can we hear from the chief executive of a national charity about their thoughts about the integration of services that are being delivered through that particular sector. So I'm going to ask one by one to the stage. First is the Right Honourable Patricia Hewitt. I'm delighted she's been able to come who's, of course, you'll know her long and distinguished political career, including Secretary of State. And some of us did some advisory roles. I know the former primary care czar was is here at that time. So I think it was 05 to 07. And the reason why all the GPs aren't smoking in the room, of course, is because of Patricia's work at that time, which has probably done more for public health than any other. And of course, many other ministerial positions. And most recently, you'll have heard about the Hewitt Review in, I think it was November 22, that she became an advisor to the current government, leading on the independent review of ICSs. And currently chair of NHS Norfolk and Waveney, and the deputy chair of North and Waveney's ICP as well. Please welcome to the stage Patricia Hewitt. And to add to the expertise from ICBs. I'm delighted that Piers Butler's here. Piers and myself go back to almost childhood. Piers is currently the chair of NHS South Yorkshire, but when I first met him, it was, here goes back in time, the district health authorities, FHSAs, some will remember that, and they were coming together to form health authorities, of which we had 100, which actually worked quite well. I became the vice chair of Wirral Health Authority, and at the time there was one, Piers Butler, who was the chief executive of the health authority. We started debating then. I don't think we've finished as yet. But since July of 22, he's become the chair of NHS South Yorkshire. He's the immediate past chair of the University Hospitals of Morecambe Bay. As I say, a long history of senior positions in managing the health service. So please welcome to the stage Piers Butler. Prof Maggie Ray, CBE, congratulations to the New Year's honours this year. She was rightly awarded the honour of a commander of the British Empire for her services to public health. Currently she is the NHSE's South West lead of the Academy of Population and Public Health, president of the Epidemiology and Public Health section of the RSM. But from the CCC point of view, she's been so helpful in connecting the public health teams in all sorts. I didn't realise that public health sat in so many different areas of academic services, HE, the council services, as well as NHS England, but has connected our sites in the southwest with that sort of expertise. And delighted she can be with us as well. Please welcome to the stage Professor Maggie Ray. Now, the next lady, if it wasn't for her, I could say we might not all be here, but Linda Charles Azuzu, who's NHS England's Director of Commissioning in the North West, had a chat with me over 3 years ago. It was the then Director of NHS North West, Bill McCarthy, who I knew from fund holding days, who I'd persuaded and bent his ear to release some money to set off the programme first in the North West. But it was Linda who put some structure around that, who liberated the cash for the first stage and has been really supportive for the whole programme right up to this third phase. Linda's had many senior roles in NHS England and the Department of Health, but I would say the chief instigator for fueling the CCCP at its early stages. Please welcome to stage Linda Charles Azuzu. And as I was saying earlier, that really important, we felt that we should have somebody senior from that sector, which is so important to lots of health and care interventions. So I'm delighted that Dr. Hilda Heo, who's the Chief Admiral Nurse and Chief Executive of Dementia UK, is with us to help us understand what is important to that sector, to have a productive interaction and team-based approach across different sectors. So please welcome to stage Dr. Hilda Heo. So thank you for being here. We thought before we start, and please have your questions prepared for such expertise on the stage, but to hear from colleagues their reflections of where we are in the process of trying to establish a sustainable approach to tackling health inequalities, and from different viewpoints how we might do that, and particularly from the CCCP what would be necessary and what would be useful to hear to enable the commissioning and the long-term implementation of some of the projects to date. So if we may, in the order I've called our colleagues to stage, and I'll join you at the end there, Patricia.
Thank you. I'm assuming somebody's going to make this thing work. It is working. Wonderful. Thank you. Thank you very much, James. I'm really pleased to be here. It's lovely to see some old friends and former colleagues, and all of us, all of you, engaged in this incredibly important and exciting and hopeful endeavour. I was talking a little bit earlier on to some colleagues from Lowestoft in Norfolk and Waveney, where I live and chair the ICB, working in two practices, both in Lowestoft on the East Coast, a mile apart, but 10 miles apart in life expectancy. And they were telling me that on the data that they have been interrogating, men in their 40s in the more or very highly disadvantaged part of Lowestoft, where one of the practices is, those men in their 40s have the health profile, or rather the ill health profile, of men in their 60s in the leafy suburbs practice. So we all know the scale of the problem. But of course, it's often in these small communities. You know, if you look at Norfolk and Waveney, if you look at the aggregated data, we have a much older population. In fact, where I live, we have the oldest population in England. But we're above average income. And yet we have these deep, deep inequalities and real pockets of coastal, rural, and to some extent urban deprivation and ill health. And we know as a health service, we know as an integrated care board and partnership, that the people who have the worst health outcomes are, of course, the least likely to see their GP, or, James, as you were saying, even to be registered with a GP. And we also know, and we are trying to create more of what actually works. And if I had to sum up what works, and I was hearing exactly this from colleagues in Lowestoft, but it's a common theme right across the integrated care systems that I looked at for my review last year. It's this powerful, transformational combination of high tech and high touch. And the high tech is the data, but also the local intelligence and insight that tells us exactly where the most at risk, the most excluded, the most vulnerable are. As I say, often the ones whom nobody is actually seeing until it's A&E, it's too late, it's the stage 4 cancer diagnosis in A&E. So the data is crucial to building the common purpose across that integrated care system, but also, particularly as we become more mature, making what will be some really tough decisions about prioritizing our resources, prioritizing our focus and time and energy, but prioritizing money as well, because there's never going to be enough money. But so the high-tech piece and the data piece and all of that, that's really important as an enabler. But of course, fundamentally, it's about relationships, because that's what transformation, that's what all health and care fundamentally are about. But that high-touch relationship that may involve the continuity of care that a good GP can provide, but it'll involve many, many other people as well. And in Lowestoft, in another different part of my own system, in many, many parts of the country, the people who are making the critical relationship with the most excluded, they are health coaches. They are local community champions. They are not the GP themselves, necessarily. They're community coordinators. They're different kinds of roles, often people drawn from and recruited from those communities themselves, because they live every day with the inequalities. They're not looking at them from a professional or purely data-driven lens. In another practice of ours, which is doing some extraordinary proactive healthcare work, it's healthcare assistants, specially trained to go out, see people, build relationships, do that prevention work. So that combination of high tech and high touch. And then final point, those relationships then enable you to tackle both the social issues, and often that's what's coming up in the greatest proportion, whether that's to do with debt or damp housing or loneliness, whole bunch of other issues. Actually bringing in the people who may well not be in the health service, who are most skilled at tackling those problems with the individuals, their families, their communities. But also, obviously, tackling and supporting people with the medical care they need, whether that's the GP, the nurse, or anybody else, in the wider primary care network, the wider integrated neighbourhood team, or some other part of the health and care system. So much more that I would love to say, but I want to hear from everybody else, and I want to hear and listen to the next session and learn from what you're all doing, so that we can think together about how we really do scale this up in the opportunity we have with statutory integrated care systems. So over to Pete.
Thanks, Patricia. What I really want to talk about is how we reframe the health inequalities debate a bit. We've had health inequalities, Jim said earlier, on our agenda for as long as I've been in the NHS, and it's over 40 years. And frankly, we've made very little impact. And we all know it's got worse in recent years. Okay. So the question for me is not, can I work a bit differently, or what schemes would work, but how do I reframe the debate to begin to make a difference on health inequalities? Because I would argue that we've not done it. And as someone who's worked in the NHS in quite senior positions for a while, we've not done it because traditionally what we do is when I'm in a position in front of a minister or a regional director from years ago, and I was in front of a minister about this 6 weeks ago, he doesn't ask me, and it was a he, by the way, Patricia, he doesn't ask me about health inequalities. He asked me about ambulance waits, 62-day cancer waits, whatever it happened to be the problem in South Yorkshire that day. And I was trying to convince him, so I'm going to try and convince you now, that actually, unless we tackle the targets differently in a health inequality way, we won't make any difference. If we frame this, and I speak as a passionate believer in making a difference on health inequalities, but if we frame this from the perspective of that's the long term, over there, health inequalities, and those nasty things over here, and waiting time and stuff are getting in the way of it, we will not succeed. It will remain a minority sport. No offence, Maggie, but that's my worry. And my view is, firstly, that's wrong morally, but secondly, it's even wrong from the perspective of tackling the targets. I'll give you an example in a minute, but the other thing I want to say is, does anybody believe that an incoming Labour government will change that view? They will not. I remember working with Patricia, who was a lovely, sensitive Secretary of State, but I also remember working with Alan Milburn, who was the most driven on-target Secretary of State I've ever seen, including all the Tories. It ain't going to change. Do you think Labour coming in later this year can say, I'll tell you what, I'll let the targets slip whilst we do more on health equalities? It's not going to happen. So we've got to reframe this debate. We've got to do something different to make a big enough difference, because it matters. The other reason why we have to make a difference is because, frankly, there's no other way to deliver the targets. What am I going to do? Build more A&Es? Have more paramedics that don't exist? The only way we can make a difference on some of these targets is begin to look at them from a health inequality lens. So I don't want health inequality to be the long-term issue. I want it to be the short-term issue, and we've got to start measuring some of the things that we do that will make a difference. If we want to make a difference on any admissions, we've got to get into communities and provide a different level of support. But see that as a short-term issue. You've got to measure it. I did some work years ago. It's a long story how I got there, with Archie Norman, who was then Chief Exec ASDA. And he said, you only do what you measure. And if all I measure at ICB board meetings are A&E weights, then I'll focus on them if I don't measure some of the health inequality issues, some of the access to service issues, we will do nothing about them. And it remains a group of happy, clappy people who are very concerned and very committed, but they've not made a big enough difference. We've got to start making a difference on some of these issues. And my plea is that we start reframing the debate. We will tackle emergency care and frail elderly by providing services in communities where they need them. That means we provide services in an unequal way, because to tackle health inequalities, I have to do it. We're doing some work in Sheffield with the 10 most deprived wards, where we're trying to provide different services to those wards. And I was on a meeting with all my four Sheffield MPs who said, this is great work, Piers. Really, really pleased with it. When are you rolling it out? And the answer is never. Because that's not how we're going to make a difference on health inequalities, is it? And we have to be willing to say some of that stuff. Because these were all Labour. You can imagine, this is Sheffield. They're not Tory MPs. When are you rolling it out? Well, actually, that's not how you're going to tackle health inequalities, is it? He said, oh, yeah, I know, I get it. But we've got to start making those kind of differences. There's some really good work done. I was at Blackpool, chair at Blackpool. It was one of the first sites on sticking a lung cancer screening in supermarket car parks for disadvantaged communities. We have made a real difference in early interventions, largely in communities we've seen previously as hard to reach, and there might be better ways of framing it. We extended it to Doncaster, made a real difference in Doncaster, but we're not putting it everywhere. But it is about hitting a today target, not about a long-term, I'd like to make a difference and feel better about it. And I think the way we're going to make a difference on health inequalities is to reframe the debate, to say, this is the only way we can deliver the targets that matter to people. And we've got to find ways of doing it. And there are ways of doing it. We're starting a conversation with the Yorkshire Ambulance Service about what we call the ambulance stack. So the ambulance have a stack of 200 people who are waiting to be seen. Why can't we intervene with those 200 people to give them a different level of support? They do not need ambulance, they do not need paramedic. They need something though, because they've called someone. And do that differently on geography, by ward, by areas that we know are difficult. We know who these people are. And you know, the smoking cessation, the biggest difference we can make in health of this population is smoking cessation. We are targeting it unashamedly at communities. We're not having smoking cessation services across the whole of South Yorkshire because, frankly, that's not how we're going to make a big enough difference. That's the kind of stuff I think we've got to do. Let me raise one other issue, and I'll stop because I'm just using examples. One of our accountabilities is around contribution to the economy. One of the things we're trying to do with all our 4 local authorities, with the DWP and with the Mayoralty, and we're very fortunate in that the Mayoralty has the same boundary as the ICP, it's only one of 2 in the country that have that, is to say, what can we do on returning people with ill health to work, most of whom are in difficult and disadvantaged communities? And we're working to try and develop some schemes with the DWP. And can we frame the money differently? Can we do that differently? Because I think if we could make a difference on jobs to those people, we'd make a bigger difference on health than anything else. And, you know, I go into, I'm not picking on them, Sheffield Teaching Hospital, and they say, to be a porter at Sheffield Teaching Hospital, you need GCSE maths. Why? How are we going to get disadvantaged communities to work? They've got vacancies. We've got to start connecting this agenda in a quicker, shorter term way. And I don't want the health inequalities debate, lovely though it is, to be just about mañana. I think we've got to make it about today. And then I think we've got a chance of making a difference in it. So that's what I want us to do, is to talk about health inequalities, about delivering today's agenda and today's targets, not just an agenda for tomorrow. And that's what I ask you to do.
That was just fantastic, both Patricia and Piers. And I have sat outside all day doing those health checks. I'm very proud of that too. So fantastic to be here, colleagues. And I think there's probably just 3 messages for me. I mean, it's a really, really special day, the 29th of February. It doesn't come along very often, every 4 years. So one thing I'm not going to do is ask you if you're going to propose to anyone today. So that's off the agenda. So that's down to 2 things I'd like to say. And I think I need to come up to Yorkshire to work with you, I think, because I never saw public health as long-term. I've never seen public health as long-term. Because for me, growing up in Scotland, what really inspired me was all those colleagues, friends, classmates that came into the classroom to let us know their mum had died, their father had died, because the vast majority of people round about us were dying in their 30s and 40s. And getting to 50 was really old. You know, that was a really old age. So again, fantastic comment about those multiple conditions. We're finding them in our 30s and 40s in the most deprived population. But I think one of my core messages is we can make a difference, because we have made a difference in the past. And I was reminding Patricia today when we met that in the early 2000s, and I'm so pleased so many wonderful colleagues that I've worked with are here today, because I used to go and really nag the life out of David when he was primary care czar. So lovely to see you here today, David, because I always believed if you had a good general practice, not just the GP, but all the people that go into general, make up a general practice, you would reduce health inequalities. Because yes, we've got to tackle poverty and the way people live their lives, but we've also got to keep people alive long enough for them to get to the older age. And that's where the fantastic skills of the whole of the NHS come in. So we need to really reframe this, so I'm with you 100%. And in the early 2000s, with our Spearhead strategy, it wasn't perfect because it wasn't an all-England strategy. It measured the difference between where the need was greatest, which, again, I don't apologise for targeting. We actually improved life expectancy and infant mortality. Not just life expectancy. People forget about infant mortality. And those 2 are the classical public health targets. And we didn't do it by long-term measures. We did it by short-term, high-impact measures to industrial scale. And if you want to see that written up, Margaret Whitehead, you'll probably all know Margaret Whitehead, Dahlgren and Whitehead, a great public health model. She did us the service of writing that up. So we can make a difference. We have made a difference. And I think it's about staying power, focus, and actually doing something on a daily basis. And that's where you come in, because that's what you do. You do it on a daily basis. You're not picking and choosing and maybe talking about it once every 6 months at the board. That's not going to deliver it. And my second point, I think, is I've really been struck by how much people can argue and debate about health inequalities. And they'd rather spend all their time arguing and debating than actually getting on and doing something. Meanwhile, everyone round about them's dying because we aren't not able to save those lives. And what do they argue about? Well, pretty much everything. We should not be arguing about data. We've got more data than we know what to do with. We're really overblessed with data. The other argument, the one that drives me completely crazy, is it's either the NHS or its wider determinants, which I think, Piers, you described beautifully in your, we'll fix the ambulances and then we'll get around to health inequalities. And people can't seem to multitask and do everything at the same time. And you probably don't have to do 200 tasks. When I was leading this strategy at the department, and it certainly couldn't have been done with just me, I only had 3 civil servants. People think there was a whole army of people there. I literally had 3 civil servants working with me. We went round and got everyone to help. And that's what you have to do, exactly as you're doing in your programme, James. It's a community. You're building a community of practice. And the big changes that could be done in the short term were mostly actually the NHS ones. And if you do them to scale, I've only got 4 priorities in my job in the Southwest, because we've moved from 600 that we simply could never deliver into 4. And smoking and controlling hypertension are my top 2, if you want to know what my top 2 are. But that debate that goes on is, it's either the NHS or it's the wider determinants. Now, as a public health person that's now been in the English context, not in Scotland, Wales and Northern Ireland, split to the 4 winds because we're constantly organised, let's make another organisation, put us in restructure, etc., etc. And then we spend all our time trying to join ourselves up again. But it's not either or, is it? It's both. And I bumped into Nick Hicks, who you'll hear in the next session, who's an old mate of mine. And we were talking, and I thought we must be twins, really, because we both have centred on a new concept that I'm going to share with you today. But please don't tell Michael Marmot till I have a chance to speak to him myself, because I'm very close to Michael, and we're running the Southwest as a Marmot region. So I'd like to tell him first myself, if you don't mind. But I'm going to share it with you because I think it's really important. We also want to reframe, and instead of saying wider determinants, we want to say core determinants of health. Because I think there's something, when we say wider determinants, it's easy to say, oh, well, it's wider determinants, not our business. Where if we say it's the core determinants of health, maybe that will convince people that it's not an either or. It's what we have to do in order to get delivery. And you know, I love delivery. There's nothing I like better than delivery. It's my favourite thing in the world. And even in the 3 months we've been working on our new strategy in the Southwest, I can tell you that 5,800 people now have their blood pressure controlled from those deprived communities that didn't have it controlled before. So again, if you're interested in results, I think that's what it's all about, because I don't expect people to just, it doesn't help us if you're just interested in health inequalities and you think that's a nice thing to talk about. I mean, you've got to move beyond the talk. You've got to deliver it. And that's why this programme is so important. And that's why, as I say, I've just felt a real privilege to be part of it in the Southwest, because that's where the action's going to happen, on the ground, with programmes like yours. Thank you.
Thank you, Maggie. That was absolutely amazing. And thank you, Piers, and thank you very much, Patricia. Thank you so much, James, for inviting me here today. I feel really privileged to have played a part in starting off the complete care communities. In the Northwest, we've had about 24 PCNs involved over the 3 phases, and they've covered areas such as mental health, learning disability, ACEs. It's been absolutely brilliant, really, really helpful for us as a region. One of the things I felt I wanted to just focus on a bit today, because I know that we'll be talking about data, the impact of the complete care communities, how they've made a difference, scalability. But I want to talk about the scalability and replication of the ways of working and the partnerships, because I think that's part of the secret sauce, basically. Certainly for us in the Northwest, where we've had PCNs working really well with the voluntary sector, with the local authority, with other types of organisations, we feel that's really made a difference for us. And I think in a time where we're looking at, certainly for primary care, how we start to, with the integrated neighbourhood care teams, how we start to really scale those teams, I think that there is quite a lot of learning that we can take from complete care communities. And I completely agree with Piers when he says that we need to obviously reframe the way we look at health inequalities. There is something about how we raise the floor and not just the ceiling. And to do that, it's things like Core 20+5 and how we start to focus on those most deprived areas of our patches. And we've seen that time and time again. So, for example, with the COVID vaccination program, which I'm also the SRO for, we found that, yes, we'd have the usual people that would come straight through the door at the beginning of the vaccination program, but it would be hard yards, kind of reaching the rest, what we call the harder to reach communities. And so I think the key to that is obviously those partnerships, the ways that we work, some of the learning from the complete care communities. I think it's scaling those partnerships and the ways of working that is key to really addressing and reframing health inequalities. And so that's why we tend to use a term health equity in addition to health inequalities, because it's about fairness, isn't it? Because sometimes you need to treat communities differently to treat them the same. Again, the example that I would use is the work that we've done with various vaccination programs, where we've actually taken the vaccine out to different communities instead of expecting people to rock up at our usual clinics to have a vaccination. So these are the kind of things that we need to just kind of think of a bit more. So it's great to talk about the impact, it's great to talk about the data, it's great to talk about scalability, but there's also something about how we scale and replicate the really effective way of working that we've seen with complete care communities. And I think that is very much the secret sauce to addressing health inequalities. Thank you.
Hello, everybody. I'm Hilda Hayo, and I have been 43 years a nurse, so I'm just beating you. So I spent the majority of my career in the NHS. But around 10 years ago, for all the same reasons that you were saying, Piers, I started to get a little bit disillusioned with the targets that I was given as a director of nursing. I started to get a bit disillusioned with how I was concentrating on figures and making the books balance, in effect. And I came into nursing to make a difference. I came into nursing to do something that I could be proud of. I wasn't proud of sitting in meetings. I wasn't proud of sitting and making some of the decisions I had to make that were basically coming down to us. So I saw this particular post come up, and I've got a family experience of dementia, both young onset dementia with my grandfather and my in-laws. And this particular day I was thinking, what do I want to do? Because this isn't doing it for me. And I saw this job that came up, and it was Director of Nursing for Dementia. And I thought, yay, that's the sort of thing for me. And it was in the charitable sector. So I thought, let's have a look at the JD. It describes perfectly what I want to do. So I started the work with the charity. And you know what? I thought, working in the NHS, I've got lots of experience. So working in the charitable sector should be a piece of cake. What I didn't realise was all the legislation behind the charity sector on top of all of the other legislation and the recommendations and the guidance and the codes. So came into the sector. So what's the difference between working in a health and social care setting and working in the charitable sector? Well, we have beneficiaries. You have patients, you have clients that you see. But we also have donors. So not only do I have to make sure that the services and support is there for the beneficiaries, I also have to make sure that the donors are happy with how we're spending their money. On top of that, we've got the Charity Commission that actually tells us as charities what we have to do legally. So there are many more hoops that we have to jump through than probably I used to have to do as a director of nursing. So working in the dementia sector, I thought I knew quite a bit about health inequalities as well until I worked in that sector. And I now realise that actually people, older people in particular, older people living with dementia, are often treated a lot less equally than other population groups. When we were arguing about targets, one of the targets, the biggest target for dementia, is how many people you can diagnose. 66%? What other condition would we be happy with 66% diagnosis rates? What other condition would we be happy? Oh yes, you've got dementia, right, ta-ta then. Unless you've got Alzheimer's type that's going to take some medication, then to be frank with you, you're sent back to the poor GPs, all of the people in primary care, and then what do? If you're lucky, you might have some service and support for dementia in your area. usually from charitable organisations, I have to say. So it's either ourselves, it's Alzheimer's Society, could be from Age UK, it could be from other sources too. But when you're working with the charitable organisations, and I was as guilty of this as anybody as a director of nursing, often there's this perception that voluntary services or third sector will do it on the cheap. Do you know what the Charity Commission says about that? We have to go out and look for people to meet our costs. So we specialise as Dementia UK in Admiral nurses. We're dementia specialist nurses. And as dementia specialist nurses, we should be paid the same as any other dementia specialism. But very frequently what we see is different sectors deciding that they will actually purchase a cheaper range of services and supports. You wouldn't get that from cancer, you wouldn't get that from any other condition. So we have some Admiral nurses that are actually placed, and I was surprised when I looked at all the list, James, at how few of the services have actually got Admiral nurses attached to them. So Norfolk and Waveney, we've got 7 Admiral nurses and 1 at Solbay. So big thumbs up to thumbs up to Trish. And I have to say, big shout out to Burnley, who are just getting an Admiral nurse in Burnley as well, which is absolutely fantastic. If anybody's interested in having dementia specialist nurses, let me just say what we do. We work very carefully with the families and with whoever is actually the hosting of the service to make sure that the complex end of dementia is catered for. When you have navigators, when you have people working with dementia at the lower end, they're not going to be able to do the cost savings that people need. So as dementia specialist nurses, we work with transitions, we work with families that have got complexity, we work with rarer dementias, we work with young onset dementias. So we're the hard end of dementia in effect. So if anyone wants any information about that, obviously I'm around until about 4 o'clock, and I've got Claire in the room as well, if you can just show yourself, Claire. Claire, so if anyone wants to discuss about Admiral nursing, I know we've had a few people talk to us already today, please do get in contact with us. So when I came into nursing 43 years ago, I wanted to make a difference. I am still hearing the same thing about health inequalities 43 years into my career. I think we in this room are all doing something about it. How many people are out there not doing something about it? And I think for me, you're the vanguard of doing that. You're the people that can talk to the people that aren't in this room to really make a difference. Thank you.
Many thanks all. There's a voice in my head saying, follow that, James. So I'm not going to, because I think it's really important now that we do come out into, we've talked about this symposium being participatory, so comments or questions, we've got a couple of mics, and I'll run round with one as well. But if you could introduce yourself, and here's a great opportunity for people who make big decisions in the health service to listen to our audience, and I'll bring some others out. And but if you could introduce yourself and then pose the question.
Shall I start? Hi, my name's Yaz, Dr. Naheed. I'm a GP at Thursby Surgery, Clinical Director for Burnley East. I just want to thank James and the team for allowing us this opportunity to be here. I've got a couple of comments, and I'm really, really grateful and totally agree with everything that's been said by the panel. I'm not as old as some of the people in this room, but no, I am old though, I am old. But 2 things I'd like to say, I'll start by saying it's relationships and trust, okay? Engagement, we talk about barriers, but if there's a willing and there's a way, you can connect to anybody if you just want to make that effort. And it's about understanding, and I'm sorry if I'm preaching, because like a lot of you have been in this game a lot longer than I have, but it's understanding and putting yourself in those residents, those people's shoes, and understanding what their problems are. Like I say, I've been a GP for 20 years. Now, one of my colleagues at the front mentioned that we used to see conditions, diabetes, heart problems, cancer. We'd see them in our patients around 60 and 70. Now we're seeing patients 30s, 40s, 50s that are getting diagnosed with diabetes, cancer, dementia, ischemic heart disease. We have to do something differently. We have to be more proactive. And this means, and I'm not stealing this from a colleague because we talked about this in a group earlier, but we always talk about fixing things when they broke. We need to do it differently and not allow it to break, because the problem is we're very, very impatient, and we can't wait 10 years and we can't wait 15 years to see the benefits of healthy lifestyle, exercise, diet, but we need to showcase that a lot more. And that needs to come from the top, and it's about policy change. It's really, really difficult to see those changes when every 5 years, because of political changes, everything changes, the goalpost changes. And I'm glad Professor Ray mentioned core determinants, because those are the key things that you have to make it work. Happier, healthier people really don't want to go to hospital, they don't want to come to their GPs, they would much rather be doing whatever they want. Now, I know I've been going on, but my question is, so we've done a really amazing project in Burnley, and we have a model that we will be clearly showing and can show that our vulnerable, frail residents will be able to live more independently in their own homes, out of hospital, with an improved quality of life, avoiding hospital admissions, resulting in massive savings to the system, as well, like I say, improving the quality of life. Not to that, just that individual, but the families, because when you have an elderly person that's got problems, families have to take time out of work to look after them. But we're trying to talk to our ICB, who is heavily overspent, and there is no money. But this, what we're talking about, is going to save thousands, if not millions, if it's rolled out to the system. So my question is, how do we get people to listen and put those changes into place? Because whatever we're talking about, obviously can't give you the secret fully, but it will work. So that's my question, and obviously we're in a room where we've got key people that could possibly answer that question for us. So please, if you could help us.
If I may, I'm going to take a few questions at a time. I'm sure we will finish by midnight, definitely. But I know there's a lot of impassioned people here with lots of things to say. If we can get a few questions unpacked, Chris, and we'll take three. If we can, we'll take as many as we can if we can be succinct with them. But if
I've got the microphone next, so I'm Chris Tiley, I'm a GP in Cornwall. The concept that inequality is a big driver for health and social problems is not complicated. My question is, what is a barrier at political level to actually understanding it?
Chris, thank you for that. Who's at the front?
Hello, yeah, I'm Jamie Gilligan, a retired GP. I used to be chair of the CCG and chair of the Health and Wellbeing Board for Surrey. The first white paper, I'm going to top this, the first white paper on care in the community was written by Sir Keith Joseph in 1973, so that's more than 50 years we've been debating this. The NHS is a socialist ideology trying to be delivered by capitalist business models where everybody is given a different allocation but expected to deliver the same outcomes. The NHS is free, but social care is means tested. When will that change to either both be free or both be means tested? Because someone has to pay for the system to make the system work and not blame the system when it doesn't.
Thanks, Joe. I think we'll just come back to the panel, then I'll come out again, because there's a lot that links into the reframing debate and how do we reframe it so that we can reallocate resources without it feeling as though there's a sector war, and how do we persuade whoever's going to be in government within a year that that reallocation or reframe is acceptable. Peter, do you want to come first on that one?
A couple of things. First is, I think the politicians understand this. Okay? There's not a politician I know, right or left, who doesn't understand health inequalities. So we don't need more we don't need more data. Getting them to do something about it, we haven't convinced them we know what to do about it, because I do think we've raised it as a short, long-term debate. So I think we've got a job to convince them this is how you make it better. Let me pick up your point at the end. The biggest problem, I think, in the NHS is the social care issue. our system just doesn't work. And if you remember rightly, Labour tried to tackle it when Andy Billman made a suggestion. He was literally hounded. Theresa May tried to tackle it and she was hounded as well. And frankly, if we don't make an impact on social care and agree a funding model, that means we all, whoever it is, has to pay more because it's not paid for, the NHS is just going to continue to be overwhelmed, regardless of anything else. The biggest shame on this country, in my view, is we're going into an election this year and neither party's got a plan. And actually, I think that's inexcusable. And you might be right that the only way to do it is social care and healthcare look closer together, and we might have to part payment in healthcare, because at the moment, it ain't working.
Patricia, would you like to?
I just want to, if I may, let me pick up on, sorry, was it Jay's? I'm 75 and my... look, this point about being in an overspent system. Norfolk and Waveney's been overspent for as long as anybody can remember, and we are finally getting a grip on things. But we're doing it through real collaboration, through solving immediate problems in more transformational ways. We've gone from worst in the country to best in the country on ambulance handovers, not by buying more ambulances, obviously, but by changing the model. But one of the problems, I think, is that too often in the NHS, we all see this thing on prevention or this thing on health inequalities has got to be funded on top of what's already being funded. And the reality is there isn't any more money. And there isn't going to be very much more money, whoever comes into government after the election. And so we have to do, James touched on this, we have to find ways of actually getting all of primary care and many other bits of the system doing what you are doing now, using as a main resource the money that's already going into primary care and some of the money that's going into acute care and the money that's going into community health and the money actually in social care, because there's an awful lot of waste and duplication and all the rest of it. So using that more effectively. But the other thing is, as several of you have said privately and publicly, you're doing this because you want to make a difference and you can see that it works, but there are plenty of other practices that aren't doing it. And at the moment, there's very little in the way of the outcomes on which practices are measured, or the way the GP contracts work and the funding flows work, that actually incentivizes and supports and funds this work. So that, for me, has got to be a really big, top of the agenda item for any new government, because if they don't change some of those incentives and funding models, then all this fabulous work goes on being a coalition of the willing and not what we need it to be, which is everybody doing it because we can see that it's the best way to do it.
May I go back out to the audience, then come back to the panel for picking up on these questions, but I'm sure we'll aggregate them up as well, because there's so many people wanting to say something. Thanks. Paul, is it? Yep.
Paul Thomas. I want to mention two words that haven't been mentioned so far amongst the enormous amount of wisdom mentioned, and that is carers and appropriate training of medical students. Now, I've been a doctor for a long time, 30 years GP, and never been a great fan of medicine, but don't you think it's a bit strange that we pick out some of the most intellectually able and altruistic children of any generation and then fill them full of laboratory science? When Patricia says it's all about relationships, she's absolutely right. Are they taught anything about how you create relationships? We know how to do this. And frankly, I've been 6 years ago, I gave up work to look after my wife who was dying from CJD, a very nasty illness. She had not one night in a hospital or a hospice and died at home. Why? Because we were able to galvanize people around our home. How much money do we save the hospital in the bed? She would have been there the whole time. But actually, mostly carers, we talk about patient-centered care, and Honestly, people really mean that. Well, how about family-centred care? Because the person who's often being hounded most difficultly is not the patient at all, but the carer. And I can give you a long talk about how terrible that is. We should be focusing on carers. They should become members of the extended primary care team. They should be part of the glue of society. They should be the means whereby we create horizontal and vertical integration of care. And they should be trained to engage the third sector. Look, it's the football clubs and the pharmacies who need to be involved in all this, and they're the people who need to be engaged in the collaborative, cooperative and continuity of care. I used to work in Liverpool 8, the riot areas of Toxteth. Fantastic. It's easy to get involved in the communities. You have to get involved in the communities. If you hide away from it, then you don't get involved in the communities. So you need a mechanism whereby you do, and frankly, it can be quite scary because it's rather a lot of work. So how about rethinking continuity of care allied to the 10% of our population who are carers but invisible? Focus on them as the new sort of like Brazilian door-to-door community health workers, as the glue of society, linked inside general practices, inside primary care networks that are compassionate communities who understand organisational learning and equity and respect and stuff like that.
Sorry, if time allowed, I think we've got most of the solutions out here. I'm going to use the cliche, the paradigm shift, but I think it's in team-based care, which is so important in care delivery, that we've got to think differently about what we mean by team, whether it be third sector or even carers. We'll take a couple more comments, but if we can be succinct-ish, but I know there's a lot of passion at the back. Thank you. Back and then front.
Okay. Yeah, so I'll be succinct. I think we need to obviously focus on certain cohorts and ring-fence funding for them. But we do also have to have shared services and shared environments which are valued by the rich and the poor. Because unless the rich value making the poor better and share those environments and share the services, they will take a charitable approach to it from a distance, watch them, try to talk about them, do television programs about them, write books about them, whilst they create their own alternative services. And already we are seeing people saying there's no money, and other people who don't actually have a lot of money are now starting to shop for alternatives. And the biggest risk for health inequalities is that the public and the profession, where professionals who don't feel treated effectively within an NHS model will choose a different employer, that will become normalised by the public, who will go on Amazon for X, Y, and Z for their Amazon GP, and we will be in a far worse situation than we are now. So I think that, during COVID, the reason we vaccinated everyone was because the rich wanted the poor to be vaccinated to protect the rich, okay, to a degree. I'm being slightly flippant, but there was shared gain in it. Likewise, interface working between hospitals, primary care and secondary care. Unless there's shared gain between all sectors, nobody really does anything. So for health inequalities work, there's no point building a children's centre that is not a nice children's centre where rich people would like to go with their children. GP practice. Data. I was at a conference very briefly, I'll stop in a second. Around the world, they were saying they're looking at the NHS, primary care, as this great example of how they will now invest huge amounts of money to try to create what we've done. Probably the biggest driver for that is our data. I remember when data sharing came through, I had lots of skeptical people coming up to me and say, oh, I don't know this, I don't know. They wouldn't have trusted Amazon with their data, but they trusted me with their data. Why did they trust me with their data? Because I was easy to get to know. They knew me, I knew their parents. I'd built a relationship. We had general practice, which was nice places to go where people had access, where we weren't keeping people away and making people fight to get to us. So I think that what we have to value is where we are now is built on where we have come from. And unless you rebuild some of this, you won't have shared data. As soon as people can choose, oh, I might go to Bupa for this, I'll go to this, you will get fragmented data, and then all of the possibilities and the options we can do now will suddenly go away. We'll then be paying Amazon for their bit of the data. We'll be trying to put bits of a jigsaw back together, whereas we have this fantastic opportunity, but it hasn't happened by chance. So I think we have to be really careful when we say there is no more money, because there is money. you know, it's just what we do with it and where we move it to. I think we have to be really mindful of creating shared spaces and shared services where everyone will want to go to, so they don't want to build an alternative, and then they may well be happy to invest in those single options.
No, Tom, thank you. Forget about my comment about midnight. We're not going to bed. Because I know there's so many, but I'm going to come front. It's amazing as well, you know, you have to come to Buckinghamshire to meet another Wirral GP, who's Tom from... come to Newham.
Oh, thank you. Oh, you remember. That's great. Great.
So there's a little bit of memory there.
Hi, my name is Kelly Webb-Martin. I head up children's services for babies, children and young people in Newham. I'm very fortunate to be in that position, but also I was a public health commissioner, so I'm really interested in everything that everyone said. My reflection in what you've said today about the unequal delivery or looking at equity is in the same way that we focus on anti-racist practice and anti-discriminatory practice, we need to probably think about health equity. But health justice, I think. I think we need to move to health justice because it's at that point it becomes more accessible to all. That's just my reflection. And the other reflection is about the core determinants. The things that I talked about with some colleagues recently was about the primary determinants, which I think is possibly around the same thing. So it's really great to hear that mentioned. My question really is, and this is focused from a BCYP, baby, children, young people lens. The more I work with young people, the more that I have the great privilege of doing community work, I realize the less qualified I am, right? And I say that, you know, because you have to be transparent about where you are. The less qualified I am, and I'm learning because there's Dr. Google, Dr. TikTok, and all sorts. So I learn so much when I deliver community programs with young people. So the challenge is, are our structures creating inequalities? Are the people that represent and make decisions creating some of these inequalities? Because in the same way that I feel less qualified the more I work with young people and the more they tell me about their experience, it's obvious that I am not representative of what they would want and need. Are our structures actually creating some of these inequalities because we don't actually have the very people who would have those lived experiences, or perhaps who are able to be the experts in their solutions, making the decisions and actually creating the policies and the protocols. It's just something for us to consider. Thank you.
Fantastic. I know there's lots of other questions, and if I may, I know Peach is going to lead the next session. We have got a bit of wiggle room in the timetable, so if we may, we continue just slightly, we get some more questions, but I'll come back to the panel first, because I know there's a ton of information. I told you it wasn't an audience, it was a participatory. But Maggie, Linda and Hilda. Oh, and the microphone. Oh.
Thank you. I mean, to be honest, I've been sitting here so fascinated, I forgot you were expecting something back from us. So I thought I'd better step up. And I'm going to go straight to children and young people, because I did mention the importance of infant mortality the first 1,000 days. And actually, it's before children are born, isn't it? And I can honestly say in the Southwest, where I'm more engaged in the day-to-day, I do have my national role, but in the Southwest, I'm on the Tuesday call with all the chief executives of the ICB. Every single one of them are completely passionate about health inequalities. They think that's why they're there, so do their chairs. But how many times have we actually had a conversation in those meetings about children and young people? They're only an hour. They're for hot topics, but very rarely. I mean, to be honest, the only thing that's made it to a hot topic is when the local maternity hospital was in a bit of trouble with CQC. So I think you're absolutely right, because if you think about all aspects of health, and if we start and call it core determinants, they're all laid down at the start of life, which for some people, recognition is before children are actually born. And then by the time you reach 12, most of the factors have already been decided in terms of your cholesterol, et cetera, et cetera, et cetera. So we can turn those around, but why wouldn't you turn them around sooner? Why do we have obese children when we don't have obese babies born? It's completely shocking, isn't it? But I also think there's hope there, because I think the best teachers are people from their own peer group. And I'm a great fan of peer learning. Obviously, someone's got to facilitate that, I think, because it doesn't always just happen. but I think we could channel the energy and the commitment. I mean, we are completely overwhelmed with the most intelligent young people qualified in the country who want to come into public health. I've got 5 training slots in my public health training program, and we had 17,000 applications across the country. So young people, I think if you go into schools, you go into universities, you will hear people that are passionate about health. And if we channeled that to help the people that haven't had the opportunities, who can't prioritise health, because to be honest, getting safely to school, often without food in the house, we could channel that. So I think I'm probably never going to be the expert on TikTok and such matters, although I do have children that help me with those things. But we don't need to be if we channel really good. And I've believed that with other peer educators in communities, etc. So that would be my feeling. How do we channel the energy of young people to help us? Thank you.
Linda, Hilda, would you like to?
Yes, thanks very much, Maggie. Agree with everything you said. And I suppose on representation and engagement, I would go back to what I was saying about partnerships, having the right partnerships. And I think that's one thing that the complete care communities, well, they've been good at many, many things, but one of them is obviously having the right partnerships. And I think that's incredibly important. To go back again to the Northwest and some of the programs that we've ran, it's been incredibly important to have what we call the trusted faces, voices, and spaces. And this isn't just involving people from the community at the end point. This is right at the beginning, to actually co-design the solution. Because we might think the problem is this, but the problem is something completely different. So an example, one of the many things that we've rolled out, the thinking was that, well, if we only had a bit more translation and interpretation, that it would be great. But actually, people didn't really want that. They wanted something completely different. They wanted social media messages in their own languages. So that co-creation and co-design is incredibly important. And we need to do that systematically, not as a one-off.
Hilda, I'll come out to the audience for one more round as well, and I can take as many as succinct you can be, but Hilda.
Thank you. Yes, co-creation is absolutely important. I totally agree with you, and that's why we have lived experience panels that consist of people living with the diagnosis and also family carers. And just to come back to family carers, our charity was set up by family carers. So we work with the whole family unit. Sometimes that's the family, the biological family, but sometimes it's family for another way. So for instance, one of the gentlemen that was on my caseload, his family was his lodgers. So he had a house and he had lodgers. They were the family unit, and those are the people that I actually worked with. So yes, we do really believe in kind of having the carers round the table as well, because often the carers know far more and have far more issues coping with some of the things that are happening than the person themselves. So absolutely, I'm definitely on the same board as you.
Hilda, thank you. If we may, we'll push, as I said at the start, we design an agenda, then I forget about it. But I think it's so important, there's so many people want to say something, we'll push it. And the good news is, the really good news, just hot off the press, my colleague David Collingbourne has been able to ring the Minister's office and cancel her because we've got far too important business going on. So unfortunately, the Minister, we've had to postpone, but I think that's important for... that's not funny, that's just true. Thank you, David, for that. So that gives us more time. So if we can, and colleagues, please, I know it's very difficult when there's lots to say, but we'll take 5, but if we can be succinct about it, we might even get some more. But a quick, so we'll start at this table, Tara, and then to this table at the back. Thank you.
Hi, good afternoon, Candice, GP in London. It's been so interesting hearing everything, and like so many of my unknowns are being aired today as well. It sounds paradoxical and interesting that, what I believe can reduce health inequalities is creating community working towards a common gain or aim. But it sounds like community is also the thing that is driving inequality. I mean, it's interesting the comment about, like, you know, the rich want the poor to be vaccinated so that they can protect themselves. But, I mean, I was PCNCD in that time, and working at the vaccination center, it was just so interesting seeing how the community got together. We had, you know, people of, well, for lack of a better word at the moment, different socioeconomic classes just come together every Thursday and Saturday and just got on and did things. And over time, I mean, for 9 months, we had no money. And everyone came to spend 12 hours twice a week giving up their time to do something for, you know, because they can. And what was really important was that they enjoyed that community spirit. And so many of them, you know, have come to say that it was that kept them alive during COVID. That, you know, their mental health got better. They actually bothered to eat, and you know, we had it was. So my question is, how do you, create community to reduce inequality and vice versa?
Thank you. We'll keep going. It's very much like being at home. As the only man in the household, when I sort of say, give directives, everyone ignores it. So we'll go with, if we can be, we'll try and take as many questions as we can. And I know there's a lot of thoughts and involvement in trying to be succinct, but let's keep going and see if we can get to David. Is it? Oh, you?
I've got a microphone here, so can I? Can I
sorry.
Go? Yeah, sorry.
Ollie.
So Ollie Hart, I'm one of the CDs from the one from Pierce from South Yorkshire, from Sheffield. I know that project with the 10 wards really well. I know they're investing, and they know what to do. They're investing in social prescribing and communities and the health coaches that Patricia was talking about. But it's a tiny, tiny fraction of the 2 million budget for Sheffield. And I guess my question to you guys as the leaders, if you're like the CEOs of the NHS, is that, you know, if you were in another business and the money you were spending was in the wrong place and wasn't getting the right outcomes, you would quickly reinvest the money where you know it could get the right outcomes. So it strikes me there's some really difficult conversations that says we've got to take money away from some things that we can always make an argument for, but put them in a place where we know they'll work better. So are those conversations happening, and how can we support you with that?
Ollie, thank you. Vincent and David, is it?
Tara's got it.
Oh, Tara, sorry.
My name's Tara. I'm heavily involved in the primary care network space. I've got two, I think, comments really. Around the word targeting certain communities. I do a lot of work with type 1 diabetes community. My daughter's got type 1, and I'm targeted, black, or my daughter's mixed race, and targeted to do things and, you know, Tara, can you come and sit on this panel because we don't have any diversity? So there is something about, we need focus effort, but not everybody responds well to being targeted for specific reasons. And then the other point is around wisdom and experience. And I don't have 43 years worth of experience. But there is a middle layer of leaders that I feel really grateful to be here, but it's very intimidating. I'm not a health inequalities expert, but I know lots and lots and lots and lots of people. And I think that there is something about, if you want to make this work accessible to people, it's just, again, I think it's around language and around being inclusive and inviting all walks of life, all different types of experiences, because we all talk to people and we could all have an impact, but we may not have project, you know, like health inequalities project experience or CEOs. So there was just, a couple of comments on being inclusive, valuing everybody, and not targeting so kind of aggressively minority communities.
Tara, thank you. Let's keep going for a while, then I'll come back to the panel, probably as the last comments. We're on the far side. David.
Just to take some points from the panel, really. I'm David. I used to be a GP, and I've also worked at policy level. And is there something fundamentally flawed with the governance of the health service? Pierce, my good mate Pierce, I was lucky to work with Patricia, but also my good mate Pierce was saying that why don't we reframe the public? Well, this is not the first time we've been saying this, Pierce. We've been saying this for years, and yet nothing happens, and we have the ambulance targets and so on and so forth. General practice, which the evidence base shows that more general practice in primary care reduces health inequalities. and yet the percentage of money within an underfunded health service is shrinking for primary care. So my question is there something rotten about the state of the NHS? And is there something more fundamentally reforming that needs to be done? Given the seniority of the panel, I'd like to know your views. But also, is the nationalised model of the health service, which tends to favour the provider rather than the customer, is that a fundamental issue? And Paul, who has spoken before, and I are part of an organisation called COIN, which is about community integration. And an extension of the primary care home, which I originated and people like Jim helped to develop brilliantly, which became PCNs, was about a provider organisation pulling everybody together. The work we're now doing is, why aren't our citizens part of that team? A bit like Jacinda Ardern said in New Zealand, we are a team of 5 million people, of course. And some of the work we're doing in this COIN is about helping the local public to be shaping how healthcare delivers. So all this is lovely stuff. General practice is good. Your plea for more focused targets and shift of target setting. And yet I worked a long time in the health service at different levels and nothing changed. So is there something fundamentally flawed, both in the structure maybe, as well as the culture of the health service, and that needs transforming before all our good wishes once again just dribble into the sand?
David, thank you. I know there's lots of comments, and I'm really sorry because we're way over time, and I do want to come back to the panel for final thoughts and reflections on all of those questions. I want to give everybody some time with that. So I know that this is a debate that could go on and on. I'm really sorry we're going to have to curtail at this point because we've got another interactive session where we will pick some of these issues up as well. But can I come back for final thoughts, comments, and I'm not going to even try to begin to summarise the questions that have been posed, but some final thoughts. Piercy, do you want to start?
Yeah,
and then we'll
let me try and pick up some of the last bit. I do worry about the future of the health service, David. And it's connected to something the gentleman at the back said about, for the first time in my life, I don't think the whole community is saying this is the right model. I think that's quite dangerous. I agree with you, if the middle class or the well-to-do, however we frame it, opt out on a large scale, I think the NHS is in real trouble. And I've got a son, we were talking about him earlier, given the work he's been doing, who happens to be a commercial lawyer in London, okay? And he's kind of, through a lot of effort from his father, reasonably liberal. But it took some effort, I need to tell you that. But he does say some, yeah, I am, oh, absolutely, and his sister's an intensive care trainee, so she's worked on him as well. But he asks a question that says, why are we the only country in the world who organise it like this and it isn't working? And the worry is, my generation says it's fantastic. But my worry is we might grow a generation who are less positive about it. And then I think what you were suggesting is what I fear. I fear for the future of it. I genuinely do. And if we can argue about funding till the cows come home, and I don't think we give it enough, but it's also increasingly taking a larger and larger amount of the GDP, which the politicians look at us. And we had this conversation earlier. I've had Labour politicians saying, it's like putting money into a black hole, Piers. Labour politicians. I worry.
As well as just the comments and the questions, could it also, as we're finalising, maybe a final message of hope and encouragement to to some of the heroes.
I apologise.
No, but some of the heroes of the NHS who are sitting out here. And I think it's just so that, because I think we're all enthused by it, but I guess there's the sort of things that might just keep the spark alive.
By the way, that was called a put down.
Patricia.
Look, I think we're absolutely right to be worried in exactly the way that Piers and you described. But yes, of course there is hope. I mean, there's hope not just in everything that you are doing and many, many other parts, not just of the health service, many other communities and community partnerships and voluntary organisations and all around the country. And what we do, I think, desperately need, it's not a conversation about a different pay, do we want to start having a means-tested NHS or whatever? Because actually, there is massive public support, even amongst the young, for the principle of a health service that is funded out of all our contributions and free at the point of need. But what isn't working is the current model of care. So we need that national mission, whatever one wants to call it, for better health. We need that different conversation amongst all of us, absolutely an inclusive conversation about what we can all do to support our own, our friends, our families, our neighbours' health. And we do need, boring though it is, a different, follow the money. Follow the money is really good advice. What has happened to the money since, look at it over the last 5 years. Because of COVID, there actually has been a really big increase in the spend of the NHS. Where's the increase been? Yes, there has. Have a look at the numbers. But it's been in acute care. And where has the productivity collapsed? Acute care, more A&E consultants, far more A&E consultants, seeing far fewer people. Primary care, no increase at all, right? And yet, primary care seeing far more people. In fact, typically seeing half the population on average every month. Completely unsustainable. So we've got to change that. And that does require some rewiring of the funding flows in the NHS. You've got some other politicians turning up this afternoon, I mean, other than the minister who isn't coming. Question them about that, because we need to change that. We really do. So that we get the money that's in the NHS, let's start with that, in the right place, supporting the work that actually will make the difference to people's lives, as well as to those immediate problems that the public quite rightly complain about.
Thank you. I just want to say a word about the money, and then there's some other thoughts on the more hopeful and positive front I wanted to give as per instructions, boss. So obviously, as an epidemiologist, we don't just look at health data, we look at economic data, because health economics is a really big part of what we need to do. And yes, I don't think there's going to be massive sums of money anywhere in the UK, because again, I'd ask you to look at the whole of the UK. This is not just a particular problem for England, so we can't really blame NHS England or English politicians. It's a UK problem with similar problems in all of the UK. But actually, if you look at the rest of Europe and other countries across the world, they simply spend more GDP on health and social care. I mean, they have different models. So I'm with, there isn't going to be lots more money, but we need to compare and contrast. So when people say they're pouring money into black holes, I do hope all of you will have your really good examples of how 1 million people a day have a fantastic experience in the NHS, and everything goes like clockwork, and lives are saved, and you know they're really happy with what we do. Because actually we are absolute rubbish at talking up the good things that happen. That doesn't mean to say the tragedies aren't there. It doesn't mean to say we haven't got that huge waiting list. And boy, oh boy, I'd love to go through that waiting list. I'd love to go through it and actually check everyone on it really needs something. Because the day in policy when we decided that every single condition and waiting time was equal was so frustrating, because it should be variable weights, I think, because it depends what you need and what you're waiting for. So, and on the hopeful front, I mean, I feel that we are well placed. We've got a job to do. We're well placed to go on and do that job. And that's how I live my life every day. And when it was, I was asked to go and help with hypertension in the southwest. I didn't sit and worry, is the NHS going to come to a standstill next year? I just thought, well, I can go off and do that. And if I hadn't gone off and done it, we wouldn't have had, and I didn't do it myself, by the way. We all worked together. We had rugby clubs, we had taxi drivers. Our best component is Eddie, the taxi driver from Cornwall, who actually was wandering around at 40 years of age not knowing his blood pressure was sky high. He's the best ambassador we could ever have. And now, as I said, 5,800 people in the southwest are not a ticking time bomb for a heart attack or a stroke, all down to really good primary care, community pharmacy, all those local services. Thank you.
Thank you. Just before we come to Linda, it was just one thing that Maggie said to me. It was at a reception about 2 years ago related to the programme. Some of you may have been there. She said, even though it's 40 years, James, it's probably the best thing you'll ever do. And I thought, after a fairly varied career, is it? And I think on the last 3 years, those words ring so true. I think it is the best thing I've done. I'm sure, with the enthusiasm in the room, you're finding that this is really sparking a step change in how the NHS might need to think about its allocations and its focus. Linda.
So, concerns notwithstanding, we've heard quite a few of them this afternoon. There is some positivity. Obeying my instructions, James. So, NHS England, we published our primary care access recovery plan last year in May, and since then, there have definitely been some green shoots of progress. And I think one of the great things about having such a plan is that recognition of the importance of primary care, as the foundation, if you like, of healthcare, and also a really key pillar stone, if you like, of addressing health inequalities in our community. So all of that is really important. And one of the reasons why I've mentioned it, without going into detail about all the different parts, the digital capability for hundreds of practices since the plan went live, pharmacy first, self-referrals enabled for patients, and all the wonderful things that have come about. There's something about how we, in our different communities, link into some of the existing levers that we have and use the system architecture so that we know that PCARP, the Primary Care Access Recovery Plan, is a massive focus for the government. So I think it's worth just thinking about how do we link into that in terms of some of our local initiatives. How can we partner, again, that partnership word again, with some of the initiatives in our systems around PCARP. So that's something to think about. We've also, in partnership obviously with the Department of Health, just recently published a similar plan for dentistry. And no doubt, I'm sure there'll be something along the horizon for other aspects of primary care. So the point I'm making is we're all doing great stuff. It's wonderful, and I'm sure that tomorrow there'll be more information about the wonderful innovation on the ground. But there's something about thinking, how do we link into the existing system architecture, the existing policies, to really help galvanize and make even more of a difference? Thank you.
So starting with something positive, I think, yes, I take your point. There's not going to be extra funding, and people do keep saying there's a black hole with the funding. But actually, I think we can use this funding a little better at times. And I absolutely agree. There are some things that we continue to do that actually, you know what, we should probably put that to one side and then concentrate in a different way. I have to say, I do feel quite aggrieved in a way that primary care gets so little of the bite of the cherry when in reality they do so much work. Genuinely feel that. I think a lot of money goes into acute hospitals because there's obviously waiting lists, there's all the different things that are measured. That needs to be redressed. And when I first came into the profession, so many of those conditions that used to go for outpatients in the general hospitals, they used to be followed up by the acute hospitals, or general hospitals as they used to call them, are now coming down to the primary care. Where has that money disappeared to? Has it followed across? Well, I can answer that question myself. No, it hasn't. Yeah, exactly. It's ridiculous, isn't it? But anyway, coming back to positive, on top of that, in primary care, you are utilising the third sector far more than any other aspect of the NHS. That is a really positive move. And we love, and I can say as a charity, we love working with primary care. That's why we actually half fund some of the posts that's coming into primary care. Because I see that primary care is the way to meet people living with dementia. Because you're the people that's going to see those people, not memory assessment services, because they see the person and they send it back to GPs. So that's why we concentrate on primary care.
Thank you. There's times where I've chaired panels and said, I'm sorry, we've got to move on now. And I didn't mean it because I was quite glad it was finishing. But really, I'm genuinely sorry that we do have to move on, because this debate could roll. And it will. But I think we need to move on to the next session. And we will catch up time, don't worry. We will be still having a hard finish at 6 o'clock, as the agenda says. It's just in the interim we may wiggle around a little bit. But before, and I'm not sure whether any of the panel can stay with us, we're having a sort of an interaction that they may have to leave because we've gone way over time. But I think it was really important to do that. And we could have rolled on for the whole of the session. But the important thing before we leave, let any of the panel go, please could you show your appreciation for their time.